All right, everyone. Next to last lecture, almost there. So we all met. I'm Chris. We're going to talk about enteral access tips and tricks. I have no disclosures. These right here are my acknowledgments. And the message I'd like to impart to you all today is actually, I think successful enteric access begins before the first puncture. And so to accomplish this, we'll talk about three things. We'll briefly discuss nasoenteric tubes. We'll talk about percutaneous access briefly, and then we'll go through some cases. So, just to briefly discuss NG or NJ tube placement, I think in really hard cases where someone's like really kyphotic, or maybe they've got some congenital deformities or really crazy hernia, I think using a 6 or 7 French angle sheath like a destination sheath or a flexure sheath can really help you out a lot. That coupled with a stiff hydrophilic wire, so either a stiff glide wire or glide advantage, I think can really kind of help you out in these difficult situations. This is a case where we're really struggling to insert an NJ tube in a patient who's got a pretty bad hernia. There's a pretty tortuous course in this patient. And then basically to kind of avoid redundancy and add support, we use the flexor sheath, which you can see here. And then in combination with a long, like 260 centimeter glide advantage wire, we were able to successfully place the tube. And so instead of like struggling to navigate those curves time and time again, I think give yourself a little bit of time, and then if it doesn't work out, just jump to using a sheath. Let's talk about percutaneous access, so G tubes and GJ tubes. So we'll talk about indications. We'll talk about patient selection. So who is an appropriate candidate and when is it appropriate to place these tubes? And then we'll briefly discuss complications and technical considerations. So G-tube indications, these generally fall into two categories, first being enteral nutrition, so patients don't get sufficient oral intake. And then second is decompression/venting, so malignant obstruction or maybe some sort of chronic ileus. GJ indications are when the stomach doesn't work, so gastroparesis, gastric outlet obstruction, maybe someone's got really bad reflux disease, or maybe someone's at a really high risk of aspiration. I think briefly comparing these tubes, it is so much faster to place a G2 compared to a GJ tube. The complication rates for GJ tubes can be a little bit higher just because you have to navigate the pylorus. And just anecdotally, I think GJ tubes tend to get blocked at a pretty high rate because people end up putting crushed meds through the J port, which you're really not supposed to do. And so I think G tubes get blocked at a much lower rate than GJ tubes. Just briefly for GJ tubes, I really like using this cope set. It's got this like nice stiff cannula to kind of get rid of redundancy. The only thing about using this, and I've seen this happen before, is if somehow you get this through the pylorus, uh, it can cause some duodenal injury. So just something to beware of. And then, always using a sheath when you first get access. If you're doing a de novo GJ and then trying to use that to kind of get through the pylorus, can help out a lot. My thing is, I always give myself 20 minutes of fluoro time max, and then if I can't get a GJ, I'm like, what, GI, it's your turn. So don't be scared to do that. So just some conditions you probably all get consulted for. So head and neck cancer, neuromuscular dystrophy syndrome. So we get a lot of referrals for patients with ALS and myasthenia gravis to place G tubes in. Acute stroke with dysphagia, which we'll talk about, gastric decompression, and then failure to thrive/dementia and TBI. Here, it's our policy. Anesthesia is automatically consulted if someone's got head and neck cancer. So bad oropharyngeal cancer, nasopharyngeal cancer, esophageal cancer, anesthesia is an automatic. And then anyone who's got ALS, myasthenia gravis, we always get anesthesia involved. And then for acute stroke with dysphagia, some of these patients, if their stroke is within 3 months, there's actually technically an ASA4. And so I tend to ask anesthesia to kind of weigh in on those patients. And then technically, if the patient had a stroke, but it's greater than 3 months, they're ASA3. So just kind of something to think about with these stroke patients. It may be better. You may be better off just at least curbsiding anesthesia and seeing what they think. Absolute contraindications to these tubes. So lack of percutaneous access. So if someone's got a really bad retrocardiac hernia, and then really bad coagulopathy. So just some anatomic considerations prior to access. So first of all, if a patient's had a history of surgery, if they've had like a Roux-en-Y gastric bypass, or if they've had multiple abdominal surgeries, they probably have a lot of adhesions. So just something to think about. Here for we always trace out the left lobe of the liver with ultrasound before prepping the patient, and even sometimes if someone's got like a huge left lobe, I'll even just thoroughly prep the ultrasound and bring it in with me and just double check before I puncture. And then barium. So we always give barium overnight here. If a patient for some reason is on the schedule, didn't get barium, we don't do the case. It gets pushed. So I don't think there's any like studies out there definitively showing that barium reduces complication rate, but I think it makes it a lot easier when you can actually see the transverse colon. So we'll talk about who are appropriate candidates and when should these tubes be placed. And so let's talk about dementia patients first. So there's actually been multiple studies showing that let's say you have two groups of patients with dementia who get a G tube and who don't get a G tube. There was a study in the Annals of Internal Medicine way back when actually looking at this, and there's no difference in survival at 60 days. So these tubes don't actually definitively prolong survival. And so I think it's always worth talking to the team and the family when we get consulted on patients with dementia. Similarly, for stroke patients, there's a study actually looking at outcomes of placing G tubes in stroke patients. And so this study basically had two arms. If you got your G tube within 30 days of your stroke or after 30 days of your stroke. And patients who got their G tubes within the first 30 days of their stroke were actually readmitted at twice the rate due to complications related to the G2 procedure. And so, I think it's always, especially with a lot of these stroke patients, I noticed that teams really tend to like push getting these G tubes in. It's always reasonable to just give them a NG or NJ tube, see how they do, because a lot of them actually do recover some function. And then TBI patients. And so interestingly, mortality is improved with early enteral support. However, a study actually looking at timing of placing G tubes in these patients found that if you actually placed a G tube within 7 days of the inciting injury, the complication rate is actually higher